So dear postgraduates, the CVD is the leading cause of the death world over. And if you see the before 40 years and after the 40 years or before 50 years of the age group, a lot of the people are suffering with coronary artery disease. You know the reasons for that. And this is, I think, the best slide of today's talk. See, macrovascular disease is a multifactorial. Already I told you everything about these factors. So hypercholesterolemia, smoking, both hypertension as well as the pre-hypertension, both diabetes as well as the pre-diabetes, abdominal adiposity, psychosocial factors, more and more alcohol, less and less fruits and vegetables, and very low physical activity. So these are all the important reasons to cause the vessels to lead to the endothelial dysfunction, or blocks, or the plaques formation, thrombus formation, platelet aggregation, etc. and etc. So if you see them, definitely all of us are having more than the 50% of the factors here. So that is the reason our people are getting the vascular diseases even at the late 20s and the early 30s. So don't think that we should have a diabetes or hypertension to cause the vascular diseases. Even without the diabetes and hypertension also, if you don't concentrate on the lipids, if you don't concentrate on the physical activity, if you don't concentrate on the fruit and the vegetable consumption, and if you don't concentrate on the psychosocial factors, we are all people are going to get the vascular diseases even less than the 40 years or less than the 50 years of the age group. So today's talk is very important talk as far as the prevention of the macrovascular diseases are concerned. So these are the risk factors, the non-modifiable and modifiable, you know that. So age is ever increasing, family history, you can't change out the parents, and the sex also, the danger, gender. So these are the non-modifiable, and the modifiable factors, you all know that. And what are the protective factors? This is the very important. So we have to upgrade our protective factors. What are they? Exercise is a very important. Physical activity is very important. High HDL cholesterol, either by means of your exercise, or by means of your high intensity statins, or by increasing your phenofibrate, etc. We have to improve the high HDL cholesterol, and of course stress reduction. So de-stress measures, meditation, yoga, these are all will give you a lot of respect as far as the vessels are concerned. So all of us should concentrate on exercise and stress reduction. So what about the burden of the dyslipidemia in India? So this is ICMR India study says that low HDL-C cholesterol is 26.9%. I say that nearly 98%. From tomorrow onwards, you see the lipid profile of your patients. You see the HDL. HDL should be more than 40 in males, more than 50 in the females, but 99% of our population, their HDL levels should get lower than the normal. So the males around 30, in females around 30 or 35. So that shows most protective lipoprotein we are lagging behind. So that means the most protective atherosclerotic lipoprotein levels, the Indians are having the low. That is the reason, even though their LDL is little bit higher, because of the low HDL, because of the no protection, we are getting the more and more vascular events. So in the lipid profile, whenever you see, you concentrate on the cholesterol, you concentrate on the triglycerides, you concentrate on the HDL, you concentrate on the LDL, and don't bother about the VLDL, because VLDL is 1/5 of your triglycerides. If you respect the triglycerides, already you are respecting the VLDL. And the fifth and most important thing is the non-HDL-C cholesterol. It is not there in our lipid profile reports, but you have to get the non-HDL-C cholesterol by subtracting HDL from your cholesterol. So your cholesterol is 200, your HDL is 30. So what is your non-HDL-C cholesterol? 200 minus 30, it is 170. So 170 is very high. You know the target of your non-HDL-C cholesterol. What is the target of your non-HDL-C cholesterol? 30 plus your LDL cholesterol target. So most of us people, we have to keep your LDL at around 55 or 75 or 70 or less than the 100. Suppose 70 is the target in your particular patient, about your LDL target, then what should be the target for your non-HDL-C cholesterol? So 70 plus 30, 100. But here with the cholesterol 200 and HDL 30, so what is the non-HDL-C cholesterol? 170. Your target is 100. So already 70 milligrams higher in non-HDL-C cholesterol is there. So this is a very important parameter. Other parameters like high LDL cholesterol, triglycerides, total cholesterol or serum cholesterol, they are all very much high in our Indian population. If you see the overall weighted prevalence of dyslipidemia in India is about 81%. So it is almost one of the important risk factors to cause the atherosclerosis. So as a physicians, we should always respect the lipids. So in seeing the reports, you need to understand the cholesterol, LDL, HDL, triglycerides, and also non-HDL cholesterol. So then where is the gap in the atherosclerotic cardiovascular control? So now the change, science has improved. We have a lot of medical hospitals. We have a lot of the cath labs. We have a lot of the physicians, cardiologists, nephrologists, endocrinologists, etc., etc. But still, the atherosclerotic cardiovascular disease are increasing like anything in a sonomic proportion. Okay. So what is by the risk score calculation? So you have the different risk scores. You have Framinghans, etc., etc., but they are not updated. Need for the early and aggressive prevention. That is a very, very important. Need for early and aggressive prevention is very much needed to control all our lipids in our target levels. So there is a high incidence of early onset atherosclerotic cardiovascular disease requires proactive intervention, not a reactive intervention. After admitting in the ICU, after admitting in the neuro ICU with a CVA, and you are treating the lipid profiles, or you are treating with Atorva 40 mg or the rosuvastatin 40 mg or 80 mg, etc., etc. So it is a reactive approach, but we need a proactive approach. So sliding scale management in the diabetes is a reactive. So you are following you are targeting the sugars, but you should be proactive. So not to have the hyperglycemia. So that is the reason sliding scale is outdated, obsolete. In the same way, in the lipid management also, you should be proactive. You should identify the people who are at risk of getting the atherosclerotic cardiovascular disease. By seeing the patient, you can identify. You can say this fellow is going to have atherosclerotic cardiovascular in the near future or not. How? By seeing the waist circumference, by seeing his BMI, by noting his blood sugars, by noting his blood pressure, by noting his lipids, with a strong family history of atherosclerotic heart disease in them, and by noting that he is a big smoker, etc., and about the sleep deprivation or obstructive sleep apnea. So immediately if you ask all these questions, if you see the records, and definitely can say that this fellow is going to have an atherosclerotic cardiovascular disease in the next 2 years or in the next 5 years or in the next 1 decade. On the other hand, diabetes under good control, HbA1c around 6.5 or 6, and blood pressure is less than 120/80, his waist circumference is less than 90 in the males or less than 80 in the females, his BMI is around 23, is a non-smoker, he is sleeping about 6 to 7 hours a day, and he is going for 45 minutes to 1 hour walk, and he is getting at least 8,000 to 10,000 steps a day, and is a non-smoker, and definitely you can say that this fellow is not a candidate for atherosclerotic cardiovascular disease. So as a physician, you should assess who are at risk of atherosclerotic cardiovascular disease and act accordingly. So that is your proactive approach. Early LDL-C reduction provides the lifelong protection. So obviously all these years we are using the statins. But what is the exact dose of the statin for that particular person? So statin therapy should be individualized. So not like that every patient should get 40 mg of atorvastatin or 10 mg of the atorvastatin, etc., etc. It should be individualized. And if there is a role for intensification of the statins, you have to uptitrate the dosages. Don't be happy with only with ecospin AV, which contains 10 milligrams of the atorvastatin and 75 mg of the aspirin. So not of much use to control your atherosclerotic cardiovascular disease. So 10 mg of the atorvastatin is not at all a very good statin. But it's a low intensity statin. But we need medium intensity statin or high intensity statin. Delayed treatment leads to the suboptimal risk reduction. So what we are all doing as a physicians is a delayed treatment, delayed diagnosis, delayed uptitration of the drugs. So in spite of your 2 visits or 3 visits or 4 visits in your OPs, still the blood sugars are very high, the BP is very high, the cholesterol is very high. So who is at fault? Not the patient. It is our fault. Not recognizing the importance of the controlling these sugars, blood pressures, or the lipids. So this is very, very important. Low awareness and screening gaps. So public awareness is very, very low. It is up to us to improve the awareness among the public. At least we may not give a very, very big speeches in the meetings, but at least whenever a patient comes to you, you please spare some time with them. So tell them the importance of the diabetes, tell them the importance of the hypertension, tell them the importance of the lipids, etc. If left untreated, so definitely leads to the catastrophic events. Many remain undiagnosed until a major event occurs. So you all know that the rules of the halves. So still today, lot of the people are undiagnosed. They are not aware. They live with the diabetes and hypertension and dyslipidemia until they get an attack. So the periodical testing of the lipids, periodical testing of your blood sugars, periodical checking of the blood pressure is always very, very important in all our Indians, because we are having very high risk of getting atherosclerotic cardiovascular disease. Early detection and the treatment strategies are very, very essential. So it makes a lot. Suppose early detection, if you detected the blood pressure, today I have seen one patient with blood pressure 240/160, asymptomatic. 3 times we checked. So once in the outside, my sister I checked, twice I checked, still the blood pressure is 220/140. So it's an accelerated hypertension. Hypertensive urgency, if not an emergency. So definitely he needs very intensified anti-hypertensive medication. So single agent may not be sufficient for him, even though his age is 26 years. So we should search for the secondary cause in that. It could be renal artery stenosis, it could be fluo, it could be Cushing's, or it could be some drug induced, etc. So definitely we have to check for the secondary cause in them, and if you find the secondary cause, lucky. If you correct the secondary cause, lifelong antihypertensive medication is not needed. Provided if the patient sees essential hypertension, the primary hypertension, so definitely we need a lifelong medication for him, even at the age of 24 till he reaches 80th birthday or 90th birthday. So this is very, very important. So early detection, the treatment strategies are very, very important. Low adherence. It's a very big problem in our Indian population. So today I have started with some drug, antihypertensive, and after 1 week or after 10 days, if they check, if they happens to be reach any hospital, then the sister will check the blood pressure, and she said that your blood pressure is normal. Then he stopped taking the drugs. Again the blood pressure will shoot up. So the normal blood pressure because of that medication. So that is a very, very important point you should tell to your patients. So the low adherence to the statins was correlated with the higher risk of cardiovascular disease, hospitalization rates, and hospitalization costs also. LDL-C cholesterol, a proven driver and the target in atherosclerotic cardiovascular disease prevention. So established risk factor linked to the coronary artery disease, stroke, and the peripheral peripheral arterial disease. See, the reduction of the LDL, about the 40 milligrams reduction, will reduce the CV events by 20 to 25%. So it is not a big problem to reduce your 40 milligrams of LDL from 140 to 100 or 180 to 140 or 120 to 80. It is not a big problem. Just you can add intensified statin and you can reduce the LDL cholesterol. So by you adding, see, always remember that you are treating asymptomatic individuals, most of these people. If you control the lipids very effectively and you are preventing him to go into the acute myocardial infarction or sudden cardiac deaths or heart failures or CKDs, etc. So you have to use these statins to reduce your LDL. Even the 40 milligrams reduction of your LDL will give you a great benefit in reducing the CV events by 20 to 25%. See, this is a very good slide. You see the LDL-C cholesterol red on the 200 milligrams, and then the 125, middle one, and the lower one is 80 milligrams if you keep the LDL. Suppose if you keep the LDL at 200, see, age at which the risk of MI begins to rise, even at the age of 35, less than the 40, you are going to get a myocardial infarction if you keep the LDL at 200. So what about the 125 LDL? So you will get an MI in less than 60 years of the age group. Suppose if you keep the LDL at 80, see even at the age of 80 or 90, you may not get a myocardial infarction. So that means that your LDL target is very, very important. Keep the LDL as low as possible. What is your LDL at the birth? What is your LDL at birth? When the atherosclerosis starts? Very easy to remember. Atherosclerosis in Chiranjeevi started way back from your birthday. From your birth. You know your birthday. So that is the day your atherosclerosis started. If you see our pipes, our vessels, our all vessels they are not the new vessels. Lot of the fibrous cap is there, atherosclerosis is there, intima-medial thickness is there. So they are already damaged. Damage already started. Started from our childhood, started from our birth. So we have to respect these lipids. We have to keep our LDL as low as possible. Maybe 40 or the 50 is the ideal LDL for all of us. It is very easy to say, but it is very, very difficult to reach that figure. But the best figure for me, as far as the LDL cholesterol is concerned, around 50. Around 50. Around 50. Okay. See here. So this is the 2025 focused update. European Society of Cardiology. So they say that low risk, moderate risk, high risk, very high risk and extreme risk. Suppose if the fellow is at an extreme risk, what should be your idea LDL target? Less than 40. Less than 40. But very high risk individual, your target should be less than 55. In the high risk, less than 70. Moderate risk, less than 100. And the low risk, less than 116. No Indian is a low risk. All Indians are either moderate risk, or high risk, or very high risk, or extremely high risk. All diabetics, either high risk, very high risk, or extreme risk. All CKDs, high risk, or very high risk, or extreme risk. So there is no low risk individuals in Indian population. So it comes under either moderate risk, high risk, very high risk, or extremely high risk. So what should be our LDL target in Indians? If there happens to be a moderate risk, less than 100. Suppose high risk, less than 70. Very high risk, less than 55. Extreme risk, less than 40. So that is the result. Just remember 50. So 50 is the best figure to keep our LDL, but it's very, very difficult. From tomorrow onwards, if you see the LDL, if it is 80 or 90, don't think that they are normal. They are not normal. They are very, very abnormal. So a lot to be done to reach your target of 50 or 70. So it is our duty to keep all our LDL cholesterol at least less than the 70, if not 50. So you remember that your LDL must be less than 70, not 100. Less than 70. Okay. So this is the Lipid Association of India guidelines. We have a LAI, that is Lipid Association of India guidelines. See the major atherosclerotic cardiovascular risk factors. 5. What are they? Age more than 45 years in males and more than 55 years in the females. Second one, family history of the premature atherosclerotic cardiovascular disease. Third one, smoking. Fourth one, high blood pressure. And the fifth one, low HDL-C cholesterol. Okay. So out of these 5 major, most of our youth, our Indian population, they will have at least 2 or 3. Number 1, we are all having low HDL, that is there. And the second one, high blood pressure. So what is the international definition of hypertension? Systolic more than? International definition of hypertension, not national definition. So systolic more than 130, diastolic more than 80 is the international definition of your hypertension. What is our national definition? 140 by 90. Sorry. So if you, what is the normal blood pressure? Less than 120 by 80. So anything above the normal is abnormal blood pressure. So we are all having abnormal blood pressures. Our blood pressure is 124/84. It is abnormal. Pre-hypertensive. Some of us blood pressure may be 130/82, maybe international hypertension. Some of us blood pressure may be 140/90. So we are definitely pakka hypertensive. So these are the there. And then what about the smoking? Are you a smoker? Yes, all of us are the smokers. Either active or passive. If not active, 100% passive. So India is a country for high smoke. High smoke. So you are all smokers, either active or the passive. And active smoking is so dangerous. So that is also there. And family history of premature cardiovascular disease. Is it there or not in us? Some of us families. So we are having atherosclerosis. My father died about maybe at the age of 60 years with acute myocardial infarction. My aunt maybe died of acute myocardial infarction at the age of 65 or 45 years, etc. So that is also there. So except the age, I think some of you, all of you are having at least 1 or 2 or 3 risk factors of major atherosclerotic disease. So all these things you should own it. Okay. And then what about the risk factors or the markers, other high risk factors? They are diabetes, they are the CKD, then the familial hypercholesterolemia, the hypercholesterolemia runs in the families. Okay. And then the extreme of a single risk factor, coronary calcium score. What is the normal coronary calcium score? 0. So when it is more than that, so definitely a risk factor for atherosclerotic cardiovascular. Non-stenotic carotid plaque, and then the lipoprotein little a more than 50. So these are all atherosclerotic cardiovascular disease risk factors. Then the moderate other risk factors, again the calcium score, lipoprotein little a 20 to 49, impaired fasting glucose. See, impaired fasting, we are all having impaired fasting glucose. You check the fasting blood sugar tomorrow, our blood sugar may be, fasting blood sugar may be 105, maybe 108. Maybe 110, maybe 115. So that means we are having impaired fasting. Impaired fasting glucose itself sufficient to cause vascular damage, endothelial dysfunction. When compared to impaired fasting glucose, impaired glucose tolerance is much more dangerous. Postprandial. All of us postprandial blood sugar may be 150 or 160 or 170, if not more than 200. So from tomorrow onwards, you should give importance not only to more than 126 fasting and more than 200, everyone will give importance because they are diabetics. But as a postgraduate, you should give importance to the impaired fasting glucose as well as impaired glucose tolerance. These two are pre-diabetic margins. Pre-diabetic people are also at prone of getting more and more atherosclerotic events because at this level also, this sugar will cause endothelial dysfunction. This sugar will cause your advanced glycation end products, more oxidative stress. Okay, so these are all the things will change. See, if you feel all these figures, all these, so a lot of our people will have most of these risk factors. Okay, so then forget about the low risk. No one is in the low risk. What is the medium risk? What is the high risk? Very high risk and extreme high risk. So in the extreme high risk, I'll say they have given the two groups, category A and the category B. Category A, coronary artery disease with more than one feature of the high risk group, and category B, coronary artery disease with more than one feature of the very high risk group or recurrent ACS. So already the patient with the known case of coronary artery disease, so that means discharged from our cardiology units, they all comes under extreme risk. So what is your LDL target in them? In extreme risk, less than 55. So maybe 35, maybe 40. So that is the very important. That is the reason cardiologists, they don't write 10 mg or 20 mg. They write straight away 40 mg of atorvastatin, atorva 40. Okay, or rosuvastatin 20 mg. So this is the very, very important. See again the Lipid Association of the India guidelines. Diabetes without atherosclerotic cardiovascular disease, diabetes with atherosclerotic cardiovascular disease. So you consider on the risk group, high risk and very high risk. So diabetes without atherosclerotic cardiovascular disease. So presence of the diabetes itself is under high risk or either very high risk. The ECG is normal, Your troponin will be negative, your echo is normal, no reasonable motion abnormality, your EF is more than 60, everything is fine, his heart is absolutely normal, but happens to be a diabetic. So the diabetes itself either high risk or very high risk. So what are the targets? LDL target in high risk less than 70, in very high risk less than 50. Now tell me, what is your goal of your LDL-C cholesterol in a diabetic? What is the upper goal of LDL-C cholesterol in a diabetic? Good. Right answer is 70. Don't cross beyond 70 in any diabetic individual. If he happens to be very high risk, so maybe less than 50 also. Okay. Now comes to the second group. He is a diabetic and also discharged from the cardiology unit with atherosclerotic cardiovascular disease. Now what are the targets? See here. LDL-C cholesterol less than 50 or optional is less than 30. In the second group, less than 30. Now tell me, what is the upper level of your LDL-C cholesterol in a diabetic and cardiology case? 50 is the right answer. So you remember these 2 points. Diabetes without cardiac problem. What is the upper limit? 70. So diabetes and cardiology case. So what is upper limit? 50. So in this cardiology and diabetes, maybe 50 in some individuals. In some individuals even you have to reach 30 also. Whereas without the cardiology, only to the diabetes. So some people 70. In some people, even without the cardiology also, you have to keep at 50. Okay. So you have the 3 values, 170, 150, 130. Now tell me the one value. Which one has to be remembered for our lifetime? 50. So remember 50. So diabetes without atherosclerotic cardiovascular disease, some people should keep at 50. So the diabetes with atherosclerotic cardiovascular disease, some people will have to keep at 50. So if you remember the 50 in a diabetic individual, you are doing lot of help to the patient. So not to have the second attack or not to have the tertiary prevention, etc. So this is the very, very important points. How will you approach this management? So not all people will require the statins, etc. and etc. First is always lifestyle measures. So therapeutic lifestyle changes. So lifestyle changes means your dietary modifications, your saturated fats, monounsaturated fats, trans fats, etc. etc. And improvement of your glycemic control, improvement of your hypertension control, and reduction of your obesity or overweight, etc. So these are all the second. And then finally the drugs. So the weight loss. Weight loss reduces the triglycerides and also increases the HDL-C cholesterol. Your activity, physical activity. So the physical activity, your exercise will reduce your triglycerides, will reduce your LDL, will improve your HDL-C cholesterol. Diet. Saturated fats, it should be less than 7% of the total calories. So how much is the carbohydrate in our diet? Ideal carbohydrate should be carbohydrate out of the 100%. How much percentage of carbohydrate? 50 to 55. Okay. What about the protein? 15 to 20%. What about the fat? 20 to 25 or 25 to 30%. So that should be our meal, total calorie of our diet pattern. So here in the fat, you are saying about 25%. Out of this 25%, you divide into 3 groups: polyunsaturated, monounsaturated, saturated. 777. Okay, that should be our ideal dietary pattern. Not more than the 7% of the saturated fats. You are consuming more than 21% means you are making more and more cholesterol in our body. What about the amount of the trans fats? How much percentage of the trans fats? 0, like your calcium score. Trans fats 0. Okay. Increased fiber. So what is the ideal fiber? How much amount of the fiber one has to take? For 1000 calorie diet, you should consume nearly 15 grams to 20 grams fiber. So usually males may be 30 to 35 grams, in the females may be 25 to 30 grams. Fiber is also very, very useful. So the interventions, so lifestyle, always important, is a lifelong. Statins, excellent drugs, and combinations. So what combination drugs along with the statins? So statin plus fenofibrate, statin plus ezetimibe, statin plus bambidoic acid, statins plus fenofibrate, statins plus PCSK9 inhibitors, monoclonal antibodies. Okay. So this is the very important. So the liver is responsible for your cholesterol synthesis. So then that will become the acetyl coenzyme A. Acetyl coenzyme A will be converted to the cholesterol. So first see the first two steps. In the first two steps itself, you will have the two drugs working on it. One in the first step, you are having the bambidoic acid. So that prevent the formation of the acetyl coenzyme A from the unity of your citrate and the coenzyme A. So that first step will be blocked with your bambidoic acid. From the acetyl coenzyme A, you are making the cholesterol. So this will be blocked by HMG coenzyme A reductase inhibitors like the statins. Okay. So see the red balls. In the first picture, not many. In the second picture, the many red balls are there. Those red balls are LDL cholesterols. Okay. So in the small LDL, even though the size is the normal, even the number is the normal, they are very small and dense. So small and the dense LDL are more atherosclerotic. So statins, where they act, HMG coenzyme A reductase inhibitor. So from acetyl coenzyme A, it will be converted to the mevalonate and then the cholesterol. So this conversion will be blocked by using the statins. Simvastatin is very popular in America. Etoro and Rosuva very popular in India. One statin which can be useful in HIV lipids, lipid abnormalities in HIV population. Pitavastatin. See the statins, they are not only in reducing your LDL cholesterol, in not only acting on the HMG coenzyme A reductase inhibitors, in preventing your cholesterol synthesis, so they are having pleiotropic effects. The beautiful actions of the statins: antithrombotic, anti-inflammatory, immunomodulatory, antioxidant, vascular cytoprotection, angiogenesis, plaque stability, and improves your endothelial function. So these are all the advantages of the statins. That is the reason statin is a must for all diabetic individuals. Statin is a must for all hypertensive individuals. Statin is a must for all high risk individuals. Statin is a must for all obese individuals. So because not only in reducing your LDL cholesterol, they also have these pleiotropic effects. So these are all the positive pleiotropic effects which can be useful not to go into your endothelial dysfunction but improves your endothelial function. So they increase your nitric oxide, which is a good vasodilator. So they cause antithrombotic effects, immunomodulatory effects. They reduce the vascular inflammation. So what is the test you test? You know whether the patient is having the vascular inflammation or not. High sensitive CRP. So what is the normal value of high sensitive CRP? Less than 1. So 1 to 3, moderate risk. More than 3 is always high risk individual. But some of our people will have high sensitive CRP 9, 10 also. So what drug will reduce your vascular inflammation? Again the statins. Which statin? Rosuvastatin, not the atorvastatin. So rosuvastatin is having a double-edged drug. Two important advantages is, one, it reduces the LDL better than your atorvastatin, and the second thing is they also reduce high sensitive CRP to reduce your vascular inflammation. So it's a good, very good vascular protective drug when compared to the atorvastatin is the rosuvastatin. So the primary prevention, yes, in all the high risk individuals you should use a statin as a primary prevention. As a secondary prevention, already had an attack, must. So statin is a must for both primary and secondary prevention. So from the day one, if you are seeing a case of the diabetes or an hypertension, you should start with a statin. So for patients with the diabetes without the atherosclerotic cardiovascular disease, use the moderate intensity statin. Between the 20 and 39 years of the age group, reasonable to initiate the statin therapy. High risk, again, use the high intensity statins. So what you mean by the medium intensity and high intensity? So medium intensity statin means your atorvastatin 20 to 40 mg or your rosuvastatin 10 to 20 mg is your medium intensity statin. What is high intensity statin? Atorvastatin 40 to 80 mg and rosuvastatin 20 to 40 mg. So this is the high intensity statin. So we need either medium intensity statin or high intensity statin, not 10 mg of the atorvastatin or 5 mg of the rosuvastatin. Okay? Minimum rosuvastatin you need is 10 milligrams and minimum atorvastatin you need is not 10 mg, 20 mg. So that you should keep in your mind. So never trust 10 mg of your atorvastatin or 5 mg of the rosuvastatin. They are low intensity statins. What we need is either the moderate intensity or the high intensity statins. Sorry. For a secondary prevention, yes, definitely for patients of all ages with diabetes and atherosclerotic cardiovascular disease, high intensity statin should be added to the lifestyle therapy. So as a secondary prevention, you need always high intensity statin. So start with at least 20 mg of the rosuvastatin or 40 mg of the atorvastatin following an attack of CVA or the PAD or the IHD. So this is the right high intensity and the moderate intensity. What is the high intensity? Lowers the LDL cholesterol by 50%, whereas the medium intensity 30 to 50%. So for example, I have given a hint. So one fellow's LDL is 200, Chiranjeevi. LDL is 200, you are a diabetic patient. So which statin you use? High intensity or medium intensity? Because what is your target? What is your target? Good. What is your target is less than 50. In some individuals may be 70 and some individuals may be 30. But average, our number of LDL cholesterol should be around 50. So what is the LDL in that particular person? 200. So what is your target? 50. So how much reduction? 150. So is it possible with medium intensity? So medium intensity reduces the LDL cholesterol by 30 to less than 50%. Whereas high intensity may be more than the 50%. That is the reason we need high intensity statin. So on the other hand, again Chiranjeevi. So your patient's LDL is 90. LDL is your 90. So what statin you use? Good, moderate intensity, because your target is 50. So how much reduction you need? Less than 50%. Okay, then you need medium. This is the most practical part. You should keep it in your mind from tomorrow onwards. So whenever you see the LDL levels of that particular person, you should know yourself what is your target in them. Is it 50? Or is it a simple diabetic without anything? So you no problem, 70. Or very high risk individual, even the 30. So at least if a target should be the 50, then what is his LDL cholesterol? If the LDL cholesterol is 80 or the 70 or 90 or less than the 100, okay, you can use the medium intensity statin. What is the medium intensity statin means? Rosuvastatin minimum medium intensity, minimum 10 to 20 mg. Okay. Ade atorvastatin aithe medium intensity 20 mg. So now always don't write 10 mg of the atorvastatin from tomorrow onwards. Minimum 20 mg of the atorvastatin or 10 mg of the rosuvastatin. Okay. If you need high intensity, straight away go for 40 mg of your atorvastatin or 20 mg of the rosuvastatin. Okay. What are the adverse effects of the statins? Myalgia. Very, very common. Rhabdomyolysis. Okay. Myalgia is a very common side effect of the statins, and also nausea, flatulence, CNS side effects, insomnia, nightmares. So they are also very common. And sometimes new onset of the diabetes. After the prolonged usage of the statins, some people may develop hyperglycemia. But finally, if you see the risk versus the gain of the statins, So what are the risks? Risks is nausea, some flatulence, or some myalgia, or rhabdomyolysis, or new onset diabetes. So these are there in only 1 to 1.25% of the population. 98 to 99% of the population, you are giving reduction of the LDL, antioxidant, reduction of the vascular inflammation, antioxidant, antithrombotic, etc. etc. So pleiotropic effects as well as your lipid lowering effects, benefits are there. They are much better than the risks. So these are the things. And very important is contraindicated in the pregnancy. So what are the drugs are contraindicated in the pregnancy? Diuretics you should not use. ACE and ARBs you should not use. Fibrates also you should not. Any lipid lowering drugs are contraindicated in pregnancy. Your methotrexate is contraindicated. Safest is hydroxychloroquine. So the statins are the gold standard of the lipid lowering therapy. So the same thing in the whatever I told you, the statins advantages. So reduces the endothelial dysfunction, increases the nitric oxide, increases the fibrous cap thickness, reduces the LDL synthesis, LDL oxidation will be reduced, vascular inflammation will be reduced, platelet aggregation will be reduced. All these things will help you in 3 ways. One is reduces the vasoconstriction, increases the plaque stabilization, and reduces the thrombosis. So finally, they reduce atherosclerosis. See the vessels here. Which one is good? The first one is good. Okay. So there is very little fibrous cap. Lumen is very good. The blood which is showing the red is very high. That means the lumen is very good. Flow is very good. And see the other 2 pictures. They are not good because they have the plaque progression, lipid pool is there, microcalcifications, thin fibrous caps, and severe inflammations. So by using the statin therapy, so what are all the benefits you are getting it at the lower side? The plaque regression. See the first one, you have started on the statins. See the result. The result is plaque regression, decrease the lipid pool, dense calcium sheets, thick fibrous cap, and reduced vascular inflammation. So these are all the advantages of the statin therapy in our individuals. So CV benefits, you have the CV benefits and also you have the risks. So the risk versus the gain, which one is more? The benefits are much more. Okay. So whatever the side effects, liver, your SGPT, SGOT may go up after the statin therapy. You need not stop using the statins until these SGPT, SGOT rise beyond 3 times more than your upper normal level of your SGPT, SGOT. What is your upper normal level of SGPT, SGOT? So some labs may be 30, some labs may be 40 or maybe 45. So up to 100 or 125, you can wait. So beyond that, so definitely one has to be reduce the dose of the statins or stop statins. Are tea vachindra chappaledu chalarpoyinda ఇచ్చేసా మళ్ళీ వెయిట్ చేసి తీసుకురండి. మజిల్ మయాల్జియా నన్ను ఎవరు పట్టించుకోవడం లేదురా చిరంజీవి, నువ్వు అసలు పట్టించుకోవడం లేదు ఏంట్రా, నువ్వు నా ఫేవరెట్ అంటే చూడరా. Muscle myalgias. So incidence of the myalgia is at most 1%. Rhabdomyolysis is very rare. Some of the people, especially doctors, we are having the side effects. One of my radiology friend is there. I started him on rosuvastatin 10 milligrams. He developed severe myalgias. Very, very intolerant. Okay. Then the kidney. Statins do not lead to the renal dysfunction. Unlike your fibrates. Fibrates may increase your creatinine levels. So that is the reason when the creatinine level is going up, when the GFR is coming down, so don't add the fibrates to the statins. Statins you can safely use in the CKD. But addition of your fibrates is again is a double-edged weapon. So if you want to add the fibrates to reduce your triglycerides, you check the creatinine level. When the creatinine levels are the normal, when the kidney function is the normal, then you add fenofibrate to your statins. Otherwise, stay with the statins alone. So rosuvastatin advantage already told you over your atorvastatin. Highest affinity towards the HMG coenzyme A reductase, tight ionic interaction, slow recovery of enzymatic activity after the removal of the rosuvastatin, relatively low lipophilicity, minimal entry into the peripheral cells, and minimal CYP450 metabolism. So that means drug-drug interactions will be very less with the rosuvastatin when compared to the atorvastatin, because our people with diabetes, hypertension, obesity, etc., they need polypharmacy. So they need more drugs. On one hand, they take the diabetic drugs, on the other hand, they take the hypertensive medications and also cardiology drugs, etc. So the drug-drug interactions are very high. So in such individuals, if you choose the rosuvastatin over the atorvastatin, so that gives benefit for the patient not to have the CYP490 metabolisms. Rosuvastatin based lipid lowering therapy for the control of the LDL-C cholesterol in patients with high vascular risk. So you know the importance of the LDL-C cholesterol reduction, because the risk of the vascular complications will be low. Efficacy of the rosuvastatin, 50 to 55% with the rosuvastatin alone, and 60 to 75% with the rosuvastatin plus ezetimibe. That is again very good important take home point. So after adding your rosuvastatin, high intensity statins, from 150 of your LDL or 100 of your LDL, your target is 50. So even after the 40 mg of rosuvastatin or 80 mg of the atorvastatin, still the LDL is at 85 or the 90. So your goal is 50 or the 70 in some individuals. Then you add ezetimibe. So ezetimibe as such is not a very potent lipid lowering drug like your hepatitis B. Hepatitis B alone won't cause any acute hepatitis or any fulminant hepatitis or chronic hepatitis or hepatocellular carcinoma, etc. But hepatitis B in the presence of hepatitis B, dangerous, very, very dangerous. So in the same way, ezetimibe as such won't reduce your cholesterol very effectively. But if we add the ezetimibe to the statins, they work wonders. Rosuvastatin alone, they reduce by 50 to 55%. Just if we add a ezetimibe, so how much percentage? Up to 75%. Okay, so that is advantage. So in some individuals, if you think that rosuvastatin is not sufficient to reducing your LDL cholesterol, then you can add ezetimibe. A lot of our pharma companies are having ezetimibe combinations. EJET, Etorva EJET, or Rosuva EJET, or Crestar EJET. So EJET is nothing but ezetimibe. So ezetimibe is 10 milligrams. And rosuvastatin varies from the dose to the dose, maybe 10 mg or 20 mg or 40 mg. But ezetimibe is a fixed dose, 10 milligrams. So the Jupiter trial, here the participants nearly 17,000 people. So they have the subjects with LDL-C cholesterol and also high sensitive CRP, but no known cardiovascular disease. They are not having any cardiovascular disease, but high sensitive CRP is elevated and the LDL cholesterol is around 130. So they have started with the 20 milligrams of the rosuvastatin, high intensity statin. They stopped early after 1.9 years. Why they stopped prematurely? Because of the positive results. So whatever all the targets they reached. So that is the advantage of the rosuvastatin. So rosuvastatin is a very useful drug to reduce your LDL-C cholesterol and also to reduce your vascular inflammation, high sensitive CRP. How much reduction of the LDL-C cholesterol? Nearly 50%. What is the reduction of the high sensitive CRP? 37%, indicating the anti-inflammatory properties. So this is the Jupiter trial. Atorvastatin versus the rosuvastatin. Here the remarks. Atorvastatin was linked to a higher 1 year all-cause mortality than the rosuvastatin in AMI patients. Now tell me which one is superior? Rosuvastatin is superior. Atorvastatin was linked to a higher 1 year all-cause mortality when compared to the rosuvastatin. So definitely rosuvastatin is superior to the atorvastatin in acute myocardial infarctions. High dose is limited with the plateau effect. So whatever the dose is increasing it, so you may not achieve very good reduction of the LDL-C cholesterol. A plateau will come. So then you can add some other drug. See, that despite the statin therapy, residual risk remains. Why? So you have started on the statins, you are very happy, the LDL cholesterol has reached your level of 50 or the 35 or the 70, but still these people are having the vascular events. Why? Because, good, right answer is, you have to concentrate on the other risk factors also. And taking the statin 40 mg and smoking 2 or 3 cigarettes a day. The BP is not under control. The diabetes is not under control. The food control is not there. The abdominal adiposity is increasing. So even though you are using the maximum intensity of the statins plus ezetimibe, etc., even though you keep the LDL cholesterol target at normal levels, so you are not reducing the residual risk. So to reduce the residual risk, you have to concentrate on the other vascular parameters. So atherosclerotic cardiovascular disease means not only the heart, but also the other factors. So all the factors you have to think of it, and you have to control all the factors in order to keep your heart at right target. Now coming to the non-HDL-C cholesterol. I told you how to get the non-HDL-C cholesterol. 30 plus LDL target. Suppose your LDL target is 50, then the non-HDL-C cholesterol target is 80. If it is 30, it is 60. If it is 70, it is 100. So non-HDL-C cholesterol is nothing but cholesterol minus HDL. Why we are giving a lot of importance to non-HDL-C cholesterol is, it is a surrogate marker for apolipoprotein B. The most prominent number one killer atherosclerotic lipoprotein is apolipoprotein B. Whereas non-HDL-C cholesterol, only your pen and paper. You calculate your cholesterol minus HDL is non-HDL-C cholesterol. So that is the reason from tomorrow onwards, you please see non-HDL-C cholesterol also. You write it on that paper, lipid profile value. So you write it on with the paper, non-HDL-C cholesterol is this much. And what is your target of LDL? So if your target of your LDL is 70, then the non-HDL-C cholesterol target is 100. Your target of your LDL-C cholesterol is 50, then this target is 80. Okay? See, non-HDL-C cholesterol and apolipoprotein B is a more accurate marker of risk of myocardial infarction and all-cause mortality risk than LDL cholesterol. Okay? So from tomorrow onwards, please calculate non-HDL cholesterol from the lipid profile values of your patients and give importance to the non-HDL cholesterol also. So measurement of non-HDL cholesterol is more practical, reliable and inexpensive. So how can we improve? Additional lipid lowering therapies are needed to complement the current therapies. What is the current therapy? All this time we discussed about the statins. Statins only. So what about the statin plus something else? And help uncontrolled patients achieve their LDL-C cholesterols. So these are the clinical challenges. Poor lipid goals achievement with a high dose statin. Even in spite of the high dose of the statins, still the goals are not reached. In some cases, not all. Residual risk reduction with the high dose statins. Statin intolerance, that is there in some individuals. I told you, some people will develop the myalgia, nausea, flatulence, etc. Non-statin drugs, what are they? Ezetimibe. To further lower the LDL, non-HDL cholesterol and high sensitive CRP, but it is not very effective alone, but combined with the statins, good work. So it interferes with the dietary cholesterol absorption, like your oglibose. It blocks the intestinal carbohydrate absorption. In the same ezetimibe blocks the intestinal fat absorption. So intestinal lipid absorption will be inhibited with the ezetimibe. So what about the timing of the combination therapy? So the CV deaths, etc. So other drugs, I told you the PCSK9 inhibitor, elorecumab and evolocumab. So this is the bambodoic acid, is another agent. So this is useful for those people who are statin intolerant. It is an inactive product that is converted to the active agent only in the liver and not in the muscle. So no myalgias. Hence myopathy is very rare. Found to be very safe and effective in patients with a residual CV risk who are on maximally tolerated dose of the statins. Side effects: hyperuricemia in the gout, tendon rupture in some cases. Dosages 180 milligrams OD and approved by all US FDA and our Drug Controller General of India. So now move on to the triglycerides. So we discussed about the LDL, we discussed about the non-HDLC cholesterol, and now the triglycerides. Once the triglycerides are more than the 500, so definitely there is a fear of pancreatitis. More than the 500. So what are the reasons? What are the important risk factors to cause pancreatitis? One is alcoholism, gallstones, and the third one is idiopathic or post-viral. Okay, viral pancreatitis, etc. And then hypertriglyceridemia. So how to reduce the triglycerides? So these are the drugs, fibrates, excellent drugs. We have the fenofibrate. Earlier we have the gemfibrozil. Now the fenofibrate is available at the dose of 145 mg and 160 mg. So you can give the fenofibrate alone in isolated hypertriglyceridemia cases, or you can add to the statin plus the fenofibrate when you have the mixed dyslipidemia. So it activates the PPAR alpha in the liver, muscle and adipose tissues, leads to activation of the lipoprotein lipase, increased fatty acid oxidation, increased HDL synthesis, increased clearance of the remnant lipoproteins. So what is the net effect? They reduce the triglycerides, they rise the HDL, they modestly reduce the LDL. So both the fibrates and the statins, they act on three parameters. Statins, they reduce the LDL, they also reduce triglycerides, they elevate HDL. So all the three can be acted by the fibrates also. Fibrates, they reduce triglycerides, they reduce LDL, they elevate HDL. Okay. So if you take the statins, 100% statins means they reduce the LDL to the tune of about 60 to 65%. They also reduce the triglycerides by about 10 to 15%. And remaining 5 to 10%, they elevate the HDL. Am I clear? So don't think that statins means 100% LDL reduction. No. Statins will reduce the LDL by about 60 to 70%. They also reduce the triglycerides by about 10 to 20%. And they elevate the HDL by 5 to 10%. In the same way, the fibrates, they also act on these three parameters. They reduce triglycerides to the tune of about 80%. Triglycerides. Then they reduce the LDL by about 5 to 10%. They elevate the HDL by about 10 to 15%. So elevation of the HDL is more with the fibrates. Reduction of the triglycerides is more with the fibrates. And reduction of the LDL is more with the statins. Am I clear? So the side effects, what are the side effects? You have the myopathy, you have the hepatotoxicity, rise in serum creatinine. That is the reason when the fellow's GFR is reducing and the creatinine is increasing, so don't add fenofibrate to your statin therapy. What is saroglitazar? It is a dual drug. Both PPAR gamma and PPAR alpha. PPAR is alpha is for triglycerides, PPAR gamma is for sugar, glucose. So when the fellow is having a diabetic and also isolated hypertriglyceridemia, then you can use this saroglitazar to reduce triglycerides as well as the blood sugar. So why combination therapy? What is the rationale to use the combination therapy? So high sensitive CRP is associated with the risk of the CV. So we need drugs which reduce the statins as well as the high sensitive CRP. Jupiter study is for the rosuvastatin. A clear link between the high sensitive CRP reduction and the lowering the reinfarction incidence. Absolute risk reduction associated with rosuvastatin within the Jupiter was the highest, 37%. So the finally, rosuvastatin and the bempedoic acid combination has 82 benefits on high sensitive CRP and LDL-C levels when combined together, reducing the severities. So the best drugs to be used, statins are best drugs. If you're not happy with the statin alone, then you can add the ezetimibe. Still the sugars are there, still the statins are very high, so definitely there is a role of bempedoic acid to be added because of the different actions. So statins, HMG coenzyme A reductase inhibitor, whereas your ezetimibe, they block the absorption of your fats from the intestines. When you use the bempedoic acid in the first step, above the level of your HMG coenzyme A, they act. So they act in the different ways so that the cholesterol absorption or synthesis will be reduced so that finally your lipid profile will be normal. Thank you very much.